Good morning, everybody, and greetings on an overcast Saturday afternoon. The weather is perfect for the talk today, which concerns a serious topic, which is usually extremely not talked about by people and talked about in whispers. We are hoping to bring it out in the open so that people are aware of it and can do something about it. The topic is what to ask, say, or do when someone close is suicidal. I'm Sunil Datta. I am a psychiatrist working at the Royal Melbourne Hospital and do the GP liaison service at the Sunshine Hospital and the Midwest Area Mental Health Service. I'm really proud to have with me Associate Professor David Horgan, who has done extensive work on this area. He will be uh, the main presenter in the program. And he's going to be very ably assisted by Dr. Amit Zutshi, consultant psychiatrist at Epworth, Camberwell. Uh, Dr. Zutshi has been on these programs earlier and needs no further introduction. We have Dr. Amita Sarkar, who has done extensive work with families in England and now is with us in Australia. And she has a lot of psychiatry in her background because her husband is a forensic psychiatrist as well. Welcome, Dr. Sarkar. Acknowledgement to the Healthcare Awareness Society of Australia, who has made this happen. They are the organizer of this event and have been doing weekly presentations, bringing knowledge to everybody, and especially to the multicultural communities who somehow get left out in this knowledge. I have to acknowledge the support of the Indian Sun TV program as a media partner in all these events. There are some silent heroes in the background who you won't see today, who are actually running this program. And they are Sid, Dr. Aziz, and Dr. Raj Killam. And I'll thank them all towards the end as well. I've introduced the topic and the panel. And if all is ready, we can start with the slides. But before we do start, the most important thing in this presentation is the audience. Please join us by asking us lots of questions so that we get plagued with lots of questions which we can answer, hopefully. And we actually have the feedback about this topic and can help you in this area as much as possible. If all is ready, then can we start with the slideshow, please? While if just let me know if it's going to be a delay with the slideshow, and if there's going to be a delay, then we might proceed with some questions before we go to the slideshow.
I think David has joined us. David,
While David is preparing for his slides, can I put a question to you, Dr. Zutshi? In the
yes,
more recent, in the more recent times, there's been a lot of talk about the rate of suicides, whether it's gone up or not gone up. There's a debatable question there, but there does seem to be an increase in self-harm behaviors, which has been reported. Could you please comment a little bit about this?
I think thanks for asking me that question, Sunil. As we know, the rate of suicide has remained around 12.5 per 100,000, and that has remained there. But the self-harm behaviors have been increasing, especially in younger younger children, in adolescents, as well as young adults. And especially so in last 18 months or so, there has been an increase in self-harm behaviors, and I can note that from my patient cohort who were doing reasonably okay. I've noticed that there have been increase in self-harm behaviors where it's self-inflicted damage to their bodies in various forms, in form of cutting, in form of increased substance use, And I think that indicates an underlying distress, increase in distress in 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 patients in general and in public, in patients in specific, because what has happened is that because of the lockdown, the usual coping skills of, you know, socialization, of talking to people, of distraction in form of exercising, interacting, and doing things, other things, has reduced remarkably. And then that's why the patients have not been able to deal with distress and have resorted to self-harm behaviors. And that's what we have noticed, at least in my clinical practice. So
That's excellent. If I could jump to you, Amita, this related to what Dr. Zutshi has just said. Um, what would you say about the youngsters and their increase in tendency towards deliberate self harm, distress in more recent times, particularly related to COVID?
Yes, Dr. Sunil, it's true what Dr. Jutchi said earlier about increase in self-harm during the pandemic and lockdown. And in my clinical practice, what I've seen, there's been increase in younger children, more of age between 14 to early 20s. And these are young people who have been struggling with lack of social connection, lack of activities, lack of active community involvement because of the pandemic lockdown. Um, a lot of time working online, doing online schooling has been quite a difficult scenario for young people. And in particular, with the high schoolers, those who are aiming towards VC, going in high school, that is the cohort that has really presented with a lot of anxiety, and anxiety turning towards hopelessness, helplessness, and they start to feel as if they can't deal emotionally, and hence they start to ride that emotional pain on their body. So there's been this more increased epidemic of deliberate self-harm in younger people recently.
Okay, that's excellent. Uh, Dr. Zutsi, if I could come back to you, there's sometimes a blurring of distinction between suicide and deliberate self harm. Um, could you comment on that and tell us, lead us a little bit through in that area about the differences and what we do with how we analyze them?
let's start with suicide. So suicide comes from a Latin word which basically means self-murder. So it's a fatal act which represents person's wish to die. And 90 to 95% of the time, there's an underlying psychiatric illness when person commits suicide. So that's a suicidal behavior. Um, Deliberate self-harm is an intentional self-inflicted bodily injury. It could be bodily, but it could be also other forms of injuries, like, people resort to increasing use of alcohol, or reducing eating and not eating deliberately. There are other mechanisms of inflicting pain, of excessive tattooing, which a patient recognizes is a way to deal with the emotional distress. And all these behaviors can be labeled under the rubric of deliberate self harm. Now, deliberate self harm is very important because it indicates an underlying psychological, psychiatric vulnerability which needs managing. It also indicates to me increasing distress and problems with distress tolerance, and also issues with poor coping, lack of emotional regulation, all the areas which can be improved on with help. So there's that. It's a cry for help. It's a mode of communication which, if uh, recognized at the right time, can help the patient a lot and prevent that deliberate self harm into becoming suicide, or actually, or suicide by mistake.
Yes. Thank you so much. I know and I realize that this topic is very private, and perhaps people just listen, are just listening to it and imbibing this. I also realize that suicide is there in the community, and we know that there is a prevalence of suicide there. The person who has committed suicide is gone, but leaves behind a devastated set of friends and acquaintances. Could I ask Dr. Amita Sarkar to comment on the impact that a completed suicide might have on the people that have been left behind?
Yes, I agree, Dr. Datta. It's a very difficult scenario, and it's a topic which really hard to talk about. Death by suicide is unexpected, but it's also violent at times because of the way the person has taken his or her own life. So, the aftermath of how the family is left about the whole scenario is really complex, and people go through a range of emotions. So usually after someone dies, after there is a loss, there is a grief reaction in people about denying, about feeling shock, feeling angry, feeling sad. But death by suicide is actually adding to the complexity of mixed range of emotions. First of all, people feel that you could have done something different, especially close family members, parents, children, spouses. They feel that they should have prevented this, they should have helped the person. So there is a rage towards self and also a rage towards why my loved one didn't trust me. Why didn't they tell me what was going on before deciding such a drastic step of taking their own lives? So that's the initial part, but other than that, there is an aftermath of how to deal with the broader community and society, because as we all know, after there is a death by suicide there is a legal framework, there's an inquiry that goes on, and there are questions asked. People have been asked to recall what was going on just before, what else could have been done. So repeatedly going back to that trauma of reliving the whole scenario, that points of contact with that person, what did that person said in the end, all those things keep coming back to the minds of those who are left behind. So for survivors, it's a very tough situation. Especially, I would like to add about how the younger people feel. So children of someone who has taken his or her life by suicide, young children don't have complete understanding what death means, and also they don't really understand what is suicide, what does it mean when somebody has committed suicide. But society provides all these complexities of people gossiping, or there is a news on the TV or newspaper. So a lot of time it's added pressure on the surviving spouse and family members to take care of how to help the children and how to deal with the scenario. Um, I would like to say that seeking help, getting appropriate help through medical, psychiatric, psychological services is crucial, because we don't expect you to deal with such a drastic, difficult scenario on your own. And there is nothing wrong in trusting the professionals or trusting those people who you find helpful in your community to really deal with this grief, because it is a difficult situation for the families.
If I may add there, I think really nicely said, Amita. Just one more thing is, when there is a suicide, I remind people that uh, the family, studies have indicated that if there's a family history of suicide, there's increased suicides in the family. So what happens is that once a person has committed suicide, the other members in the family, it could be second generation, third generation even, they start recognizing suicide as a way out. It becomes an option. It becomes an option. If things don't work out, then it becomes an option. And it's something which people have to remember, that if they commit suicide, they are giving a way out to their generations of their kids, grandkids, that there is a way out by committing suicide. So that is something which people have to be reminded of.
Thank you so much. That is so good. And there's often some a saying that of every person who commits suicide, there's about 130 to 150 people who get affected by that, from first responders to distant relatives to doctors to GPs. And on that note, I'd like to reintroduce Dr. David Horgan, who's going to present us with a set of slides and talk us through them and a small video as well. Welcome back, David.
Thank you very much, and I really apologize to everybody who for the gremlins interfering with the connection this morning for some reason. So I hope everybody can hear me. I will, without any further ado, move on and talk about my presentation. So I'm going to talk about what do you do in the very common situation for a friend suicidal. And this is, I think, one of the most frightening things that can happen to people, and people feel quite frightened, afraid they don't know what to say or what to do, afraid they will say the wrong thing, and feeling totally helpless. And we want to change that with this new initiative, which indeed is considered a worldwide initiative. None of the experts have heard about something like this before. So let's talk about our annual figures in Australia. In fact, if somebody under 45 dies as a young adult, the question, it's the most likely cause of death or injury, unfortunately, is either suicide or an attempt at suicide. And I won't blind you with numbers, but if you just think, a bus full of people die every week from suicide, a plane full of people attempt suicide every day, and for every attempt, we say between 2 and 3 people are strongly thinking about suicide, not just casually, but strongly. Casually, somewhere between 3 to 6% of populations worldwide have thoughts of suicide. Now, we actually have come up with this new concept of in tough times text, which is actually a way of giving immediate suicide prevention, something you would have thought is not possible. Because the usual advice, of course, when somebody is suicidal is to bring the person to a professional or call a crisis service. But that's all very well. Professionals aren't available. Crisis services are overwhelmed. A lot of people are really not willing to join or contact a service. But will, of course, listen to family and friends. And there are never, given the numbers I've told you about, there are never going to be enough professionals. And they're all busy. And even if you see a professional once, what is that really going to solve? Because suicide risk can go on for weeks, maybe months. And indeed, the problem is that most suicides and attempted suicides occur outside business hours. They don't happen 9 to 5, Monday to Friday. They happen nights, weekends, as we all know. And you can't always tell who is suicidal. Many people have suicidal thoughts. This was written by a very smart young woman I was treating. Tonight I smiled, laughed, and showed energy and sparkle, made jokes. Whenever I looked out the window into the rain, though, I relaxed for a second and thought privately, more than anything, I wish I was dead. Then I turned back and smiled again. I know in a calm, melancholy way that I might as well die, that I'd be better off. But you're not going to be able to tell. So, and let's also understand that suicidal thoughts are on a spectrum of severity. So the lower end is, I wish I was dead. I wonder, would that solve my problems? To, at the upper end, being totally convinced suicide is the only logical solution. A useful thing to ask somebody, believe it or not, is, can you remember what you have read? Because I actually see this as a marker of damaged brain chemistry. It's one of the first problems people have when they get depression or severe symptoms. It is one of the last things to recover. If then you may want to say, do you wish you did not wake up in the morning? That's a reasonably socially acceptable question to ask somebody if you have these sorts of concerns. And then if they say yes to that, you might ask, have you thought of doing something to yourself? And if so, on a 0 to 10 scale, how strong are those thoughts? And why do people suicide, you may ask? And the reason is, in fact, they suicide to escape emotional pain. because something convinces them the pain will never stop. And there are two major things in our society that cause emotional pain: depression, the illness, which I will talk about in a moment, or a disaster in people's lives. And this is a quotation from a doctor who says that depression is more painful than the kidney stones he had or the heart attack he had. So it's all a useful thing and a strange question, perhaps. But ask people, how bad is their emotional pain? Low, medium, high. Depression is a very common illness. 10% of men, 20% of women are going to get it at some stage in their lives. And we have grave fears that large numbers of young adolescent people and teenagers are getting touches of anxiety and depression when they're quite young. And we know the symptoms of depression. You can list them in a textbook. I won't go through them. But what fundamentally depression tells people are these sorts of things that I've written down. You are alone. No one understands. No one can help. The pain will never stop. You are a burden. You are worthless. And they get hammered by these thoughts 24/7. And that's what pushes them to thinking suicide is the only logical solution. The emotional pain typically that people get suddenly are relationship disasters, where a relationship suddenly is ended, or people feel really humiliated, or financial disasters. And people then have an impulse to stop the pain, and friends and family can intervene immediately. And this is what is really important, is that we are offering immediate intervention. And in fact, if you want to, in toughtimestext.org, you can pick a message and just select it, and it will download as a text or as a WhatsApp message. And so it's a very quick and useful system, and we have hundreds of messages, which I will mention. So these are the features that we have on this website, and this website is available 24/7 to anybody, no training required. We do ask for more input and suggestions, but we have what to ask somebody who's mentioned suicide, what to say, what to do, and then a few other things connecting until recovery, or perhaps it's more critical and dangerous, so we actually have advice about what to do in a crisis, ranging, telling you the crisis services that are available, to when do you have to override what the person is saying, please don't call anyone, and make a decision for you have to do this, and how I recover. So this is an example what to ask when somebody mentions suicide. You might then ask, do you wish you did not wake up in the morning, which I've already mentioned. And messages inquiring how somebody is from your phone to the person you know are very striking, because personal connections are one of the major things that determine whether or not people in despair decide to attempt suicide. So if I was to send a message to a friend of yours who was suicidal, it really wouldn't have any impact, or a trivial impact. But if you send a message to a friend, it has a huge impact. And that is the core issue. And this is what you would see on the website, multiple messages, and you will see the bottom row has a black box, and behind that there are multiple other text messages. Any one of them you can select and send, as I say, as a WhatsApp message or as a text message. And then we go on to what you can say. And one of the things is that we emphasize is you would never advise a friend to die. Tell yourself what you'd tell a friend. We are all very good at giving advice to other people. And in the heat of the moment, we may, however, not think what would we say to somebody else. Or we also say things like, if you look down on the second box in the second row, is there anyone close to you whose suicide would not damage you? Your suicide would destroy so many people, because many people with depression see themselves as a burden, and the illness tells them they would be better off and everybody would be better off if they weren't around. So it's important to contradict that. And as I say, yes, repeat myself, this is a very useful thing to say to somebody who is thinking, I want to die. They would never tell somebody else with a whole list of problems, I think you should kill yourself. So tell yourself what you would tell a friend. What you can do, I will let you read that on the website. Keep texting people, encourage them to talk, encourage them to see a mental health professional, organize it for them perhaps. And as we finish, so I'm just emphasizing that the most important thing for very many people is anti-suicide messages from the people closest to them in life. And this can be turned on immediately. It is an immediate safety net as soon as suicide is mentioned. And so it offers protection and in between visits to a GP or to a mental health service, or indeed if a person is reluctant to go to see such a service, although one of the rules, so to speak, of having a problem is that you will take appropriate treatment. So what can you do in your community? We actually don't want your money. We actually do want publicity, please. So I would hope everybody watching this broadcast can get some publicity on social media for this service. And this is just summarizing what we've said before. So thank you.
That was excellent. That was excellent. And so much useful material, David. I might come back to you with a few questions down the track, more specifically related. But we have a few questions from the audience.
Can I ask first that we run our video? I was meant to give some warning. Please, this is a 99-second video which summarizes the system in action.
Has someone close to you mentioned suicide or wishing they were dead? Our normal reaction is to feel frightened and unsure what to say, in case we say the wrong thing. In toughtimestext.org is a new dimension in suicide prevention to assist in the care of the 100,000 people each year driven to attempt suicide. It is a safety net provided to the community to wrap around a person at risk. Family and friends are given access to hundreds of support texts that can be instantly downloaded and sent as messages from their own phones to a suicidal person. This can have a huge personal impact, persuading the person with suicidal thoughts not to act on these thoughts. We cover what to ask, say, and do. Just click on a message and it will download to your phone as a text or WhatsApp message. Under what to ask, there are texts about how the person feels. For example, do they wish they did not wake up in the morning? Under what to say, you can find text suggestions such as, you would never advise a friend to die, so tell yourself what you'd tell a friend. Under what to do, there are resources for ongoing support and involvement of a mental health professional. You no longer have to feel helpless or at the mercy of professional waiting lists in this concerning and urgent scenario. Without any training, you can use in toughtimestext.org with the knowledge that these support text messages are medically approved by the Australian Suicide Prevention Foundation.
Once again, thank you once again. It
you.
covered. It's so useful to have this information, and particularly for youngsters, I think, who are so tech savvy. They love the anonymity of being able to interact in cyberspace and on social networks. I think it will be such a useful intervention, and I hope it gets taken up by widely, extremely widely. We have a few questions from the audience that I'm going to come back and forth with, and then there are lots of other questions to cover as well. The first lot of questions related to international students. What mental health support can they get? And it does look like this app that you mentioned, David, is freely available to everybody on the net. Could I say that it's available worldwide almost, or just here, or?
It's certainly available worldwide if anybody knows about it. And that's why it is so important especially with such a wide multicultural group watching the video, that people in their own countries know about it. And indeed, we have Google Translate for many of the aspects on the site, so that it therefore can be used by multiple different languages.
Excellent. And in addition, we've got Lifeline 131114, always there, always a useful resource. It's manned 24 hours, and it's this helpful in guiding people where to take help. Beyond Blue is always there. Keep in mind that's 1-300-224636. That's Beyond Blue. And for the kids, there's a kids helpline, the 1-800-55-1800. Simple number to remember.
Okay. Could I say that on the website we have all these crisis services listed, their hours of operation, whether they operate by video or by telephone, and the sort of services they cover, so that it's a very useful reference for people in Australia, and we hope therefore it would be replicated in other countries.
Excellent. All right. Dr. Amita, there's a direct question for you. How can teenagers with self-inflicted injuries be detected early before they reach the suicidal stage?
Sure. It's a very relevant question, especially for parents when they learn about the child self-harming, because it's an emotionally very distressing situation for them. Even before it's detected, some of the behaviors that often we note and parents report is the young person, the teenager, starts to become very secretive. So if you start to see any substantial change in behavior, in social, emotional presentation of your teenager, that is the time to really just check with them if everything is going okay. Because self-harm is a behavior which is more like a tip of the iceberg. There are deeper underlying mental health issues going on there. If you find your child is kind of covering body parts, not very willing to wear outfits for swimming, sports that can reveal their body parts, those are the things that young people who are self-harming on arms or legs, they try to kind of cover up. Secondly, spending a lot of time by themselves, not interacting with the family, not sitting together for family meals, refusing to talk about anything, what's going on in their lives or with friends. Those are the signs and signals where there is a reason to express concern, but also with kindness, love, and not being judgmental, helping the young person to see that you are there to help if they need any help. If we come to the next stage where it has been identified that your teenager has been using means to self-harm themselves, initially it is hard because parents feel that they have to fix it, they have to do something to really make it better for their child. And the crisis is the intense point where everybody is involved, the professionals, doctor, parents, family, school, everybody has got a way to help the child. But the difficulty arises that after the crisis has been handled, if there is no safety plan in place, then the chances are the young person will revert back to the same way of coping with their emotions, which is harming their body to feel the pain or deal with the pain. That's where it is important to look at the underlying factors and what it means, as Dr. Zutshi said earlier, about depression, anxiety, any other kind of mental health issue that is causing a young person to feel distressed and using self-harm behaviors to deal with the emotional distress. Counseling, psychotherapy, getting support is really important. And I would like to tell the parents that if you feel that your child is not confiding in you, but they are rather willing to talk to a professional, don't feel that they are rejecting you. They are just trying to understand, they're just trying to work out what's going on because they are confused themselves. So allow some time, allow some space and confidentiality to your young person to engage with professionals. And most of the time, when we see a young person using self-harm as a coping strategy on a regular basis, there is a combination of individual therapy, but also family therapy and family counseling is always part of when we work with young children, middle age or middle school children, or even teenagers, to help the parents to see how to interact with your child, giving very practical strategies. One of the very quick tips to say is, at any point where you see that there are factors that involve some kind of family conflict, you need to really reflect back on, is there anything that I need to work on? If there is anything that is going on between mom and dad, or between older siblings and parents, that's having an impact on this young person. So really taking a more comprehensive view of what's going on in the environment of this young person is important.
Excellent. Thank you so much for that. Thank you so much for that. I have lots of questions from the audience, so I might have to just quickly keep moving on, if you don't mind. And perhaps the next question is towards Dr. Zutshi, and if you want, David, you could add on after Dr. Zutshi as well.
Sure.
And this relates to stigmas and taboos surrounding suicide and mental health. I think we are all aware of the stigma that goes around with mental health, and particularly with suicide. Would you like to give any comments on that, Dr. Zutshi?
Yeah, there's a lot of stigma around suicide and mental health, as we all know, and that is an area which prevents people from seeking help. And that's an area which we all need to target. And I think starting from the university, from school, with the kids, and talking about how to communicate about distress and making it normalizing that whole process could go a long way in reducing the stigma. I think it's being able to raise your hand and seek help, and encouraging resilience, while also being able to say that, acknowledge that we all can be vulnerable in different moments, moments of difficulties, and being able to communicate that to our parents, to our loved ones, and also to seek help by speaking it to our GP or the psychologist or psychiatrist. I think that's something which is very important. Also, making sure that, because media plays a huge role nowadays um, in a person's life, especially in a young person, in a teenager's life. So making sure that mental health is depicted in the right way. We all know how much damage movies and previous serials depicting mental health in a very negative fashion has had an impact on mental health and suicide. So making sure that we are depicting mental health in the positive way, where people are allowed to seek help and encouraged to seek help, I think that will go a long way in reducing stigma.
That's excellent. David, would you like to comment on that?
Sure.
Or
I think we all say the same things about stigma, but the harsh reality is that there's a huge stigma about mental illness and its treatment, unfortunately. It is a generational thing. Beyond Blue is slowly changing it, but it is going to exist for a long time. People in the workforce get discriminated against if they say they have depression, unfortunately. So I think what really matters, as Amit was saying, is find someone you can trust. Some people will be prejudiced and have a stigma against mental illness or depression or anxiety, and other people you will know are tolerant and educated people. So what you need to do is pick your audience and before you confide in someone.
excellent, excellent. There is another question, and I'm going to. This is a deeper question, and perhaps maybe David, you could start the ball rolling with the answer to that. This relates to people who have survived a suicidal attempt. Do they change their perception to life after that? Do they change in some way or the other? Is there a personality change? Basically, the question is addressing after a suicidal attempt.
There's not a personality change, but they have now become literally the highest risk group of suicide in our society. Once somebody has attempted suicide, their chances and survive the attempt. Unfortunately, their chances of dying from suicide are now 100 times the chances of everybody else in the population. And in effect, they've crossed a line mentally. They've thought about it, agonized about the decision, perhaps, then made the attempt. They are now predisposed to doing it again. And it's almost like a suicide attempt has become normalized in their mind. So it's not so much they undergo personality change, they undergo a philosophical shift. And it now becomes too easy an option, and it requires a lot of discussion. Now, let me not frighten you with the statistics when I say they're at 100 times the risk. 20% of people who attempt suicide will repeat, apparently. Of people who have attempted suicide, 2% of the women and 5% of the men will die from suicide later in later years, especially in the first 12 months. So a lot of support in the first 12 months protects people.
Excellent. My next question is directed towards Dr. Amit Zutshi, and it relates quite closely to our multicultural community. In relation to what is the risk of suicide in overseas immigrants? And what are the factors that we have to keep in mind, specifically in relation to this community?
That's a very pertinent question, given the forum we are in. I think the multicultural, the overseas communities, overseas immigrants who have moved in are at a higher risk of mental health problems because they're moving. But at the same time, studies do indicate that when they evaluated the first generation versus the second generation immigrants, they realized the first generation, because they made that decision to move, they can cope with the transition, they can cope with that movement and movement across cultures in a slightly better way. They are more skilled at dealing with the stresses which accompany with this immigration process. However, also, I need to note that underlying trauma or the background trauma, like whether they are running away from a conflict zone, whether they have been traumatized and have experienced violence themselves in various forms, also tends to color and predispose them to mental health issues. However, definitely all the studies do indicate that it's the second generation which is at highly increased risk of mental health plus suicide, mostly suicidal behaviors, because there's that cultural confusion, the confusion of whether to follow the culture of the adopted country or the country of origin of their parents, the pressure from the parents, also the disconnect at times with the peers, and that whole stigma about mental health and inability to communicate about their distresses to their family and to their loved ones increases that vulnerability and increases the risk to mental health issues. So we have to be mindful that it's not only the first generation, but most importantly, the second generation immigrants, which are at increased risk, and that monitoring needs to continue.
Thank you so much, Amit. And please don't be frightened. We have a flood of questions from the audience coming through, which I'll be directing to everybody one by one. And one of the questions that's come, there's a nice challenging questions that are coming up. One of the questions that's come up is, what's the difference between a cry for help, which basically translates into what's the difference between unhappiness and depression? And I guess I might start asking David that, and then the rest, everyone else is happy to join us after that if David's after David.
Right. And certainly people talk about, say, I'm depressed when something goes wrong in their life. But being unhappy when something goes wrong is perfectly normal, and it would be abnormal not to be unhappy when things go wrong. So what really matters, I think, is number one, can the person concentrate? As I say, can they remember what they read, or can they remember what's going on TV automatically? Secondly, depression is always there. It may fluctuate in its severity, but I often say to people, if I rang you up and you were out with friends and apparently having a good time, would you tell me the depression is totally gone? Or would you say it's there in the background? If it's totally gone, it means this is unhappiness which comes and goes. If it's there in the background, it means the depression is always there. So it's more like an illness. A cry for help is an interesting phrase, because the reality is there are two parts that make a decision when somebody attempts suicide. The sick bit wants to die, and the healthy bit wants to live. And that is why people make attempts of varying degrees of determination, depending on which one is most in control. So all attempted suicides, if you like, are a battle between the cry for help from the healthy bit and the determination to die from the sick bit. Thank you.
Dr. Amit, would you like to give some comments on that?
No, I think David has answered most of it, but just adding on, I think it's important to differentiate the difference between distress and depression. I think let's agree that we all can be distressed at different points of times, and that's where it's important to understand that whether the cry of help is more and because of underlying depression, anxiety, or it's just underlying distress. Now, because distress, if there's distress, for example, we know immigrants who are locked up or who are not allowed to lead a normal life because of issues with passports, with issues with their this being citizens. Now, that is a distress initially, and if we can help them problem solve, provide the right referral to right organizations so that that can expedite it, then that distress could get better. However, yes, if the distress is allowed to continue after some time, after a few months, after years, depending on person's coping abilities, that distress leads to hopelessness, and then it can become depression, and then it becomes it has to be treated biologically. However, initially, also that distinction is important, because if we label distress as depression, then what we are communicating to the patient is that you don't need to do much. We can help you with medications only. I think having that link that yes, you are distressed and this is a very difficult situation to be in. So validating that distress, but also helping to see at problem solving, trying to encourage better coping skills, and fostering resilience. I think that's key, because then the patient also invests more, acknowledges, okay, this is an issue and I need to work on this. I think that's where, as psychiatrists and psychologists, we need to differentiate that and help the patient in the right direction.
Excellent. All right. The next lot of questions, I'm summarizing a few questions, and Dr. Amita might want to comment on them, relates to primary prevention, secondary prevention, and tertiary prevention. As we know, primary prevention is trying to prevent yourself from getting unwell. Secondary prevention is trying to detect the illness early and preventing it from becoming worse. And tertiary prevention is once it's already established. And as David mentioned, once they've had a suicidal attempt, how do we subsequently reduce the impact of that illness on them? So one of the question I'm directing to you, Dr. Amita, relates to primary prevention. And how can we primarily prevent these things from happening in the first place?
Sure. I'd like to start with what Dr. Zutshi said about the socio-cultural environment and also building resilience. Resilience is a concept which basically, in very plain and simple language, means ability to bounce back, ability to cope with failures and again come back to life and deal with the stresses in life. For children, for young people, starting from early age, from going from primary to secondary school, we can see that there will be a number of changes in young person's life. So physically, biologically, emotionally, everything changes for them. Um, as much as for a child, parents have to look after a toddler to make sure they don't get hurt physically, to keep them safe. I'd like to say that for young people, for teenagers, it's important to keep them emotionally safe. And if we can help to keep our child emotionally safe, that is the first foundation to start building resilience in them. What it means is we help our child to be able to open up and talk about if there are any difficulties. We don't judge them based upon whether they are achieving or they are failing, but we also help them to see that if there are failures in life, how to get help, how to find solutions, how to problem solve, as Dr. Jutsi said earlier. Developing all those skills are part of developing resilience in a young person. Emotional regulation, and in a very plain and simple language, what emotional regulation means is, if I'm feeling upset, if I'm feeling angry or distressed or sad, what are the ways I can use to feel better and come back to feel more normal again? What it means is, sometimes people have to talk to someone if they are upset. Sometimes people have to get practical support, financial support, physical support, informational support, and solve the problem. And that can help them to really feel able to connect with everyone. Connecting with others is another area which can be supported for developing resilience in young people. Now, we know the world is very different now. We have got a lot of technology around. We have got young people having their own virtual world on their phones and iPads. For a parent to be able to enter a child's life, they don't have to just be judgmental and say, you can't do this, you can't do that, because that's what we did. We have to acknowledge, I mean, you have to realize that they are a different generation. So acknowledging what is different for your child as compared to what you did or didn't do as a child, and also trying to understand their inner world is important. So as much as we help the school to support our child completing their homework, getting them to school on time, uniform, all those things, emotional support and scaffolding emotionally, making sure the child is able to deal with the distress in life, is the cornerstone of developing the resilience in children. If we
Excellent.
find that, sorry.
That's wonderful. Wonderful. Yeah. So look, we've got 5 minutes left. I just want to summarize a little bit, and then I'll move on to thanking the audience. Deliberate self-harm is a way of communicating distress. It provides someone with a temporary relief from their emotional pain. However, it can lead to stigmatization, marginalization, and various consequences for the person who's harmed themselves. A quick sort of summary of what do you do when someone is feeling like harming themselves. I've got my 4 Ds, which I normally share with people. And the 4 Ds are delay, distract, divert, and deep breathing. So delay is managing the moment. Manage that moment when you're feeling like self-harm. Distract. You can use the rubber band technique. Cause yourself some little pain. Pull the rubber band on your wrist and harm yourself, and that just serves as a minimal distraction. Divert. Have a little resources folder that you can look at with pictures of your pets or something like that that you can focus on, and that'll just divert yourself. And then do a deep breath, and then look at yourself. And I tell people to recognize anniversary reactions, like birthdays, anniversaries, specific events, specific places, which might lead to them, or even specific emotions. Sometimes anger triggers them, or sometimes substance abuse triggers these things. And a quick summary of what I try and tell people about grounding strategies, which is so important at that time, is to use my three objects technique. That is, with your eyes, look at 3 things around you. Look at the room, perhaps look outside at the tree, and identify 3 things around you. With your ears, try and hear three things. Can you hear the sound of the water tap? Can you hear the sound of the wind? Or can you hear something else? Three sounds that you can identify. And then I tell them, look at three different parts of your body and try and move them. Move your tongue, maybe move your finger, and maybe move your toes. And then come back to that feeling. And I usually find that having done these, we've managed the moment, we've used some distraction strategies, and that immediate impulse of harming themselves has gone down. Now, coming back to the audience, would you have any last words to add to the to from our team of experts to the audience? Any last words that you want to give to the audience? And this have to be just a few last words. I'll start with you, David. Any last words that you want to share with the audience?
This is a worldwide problem, and as I say, we don't want money. We would just please like publicity. This will make a big difference to people around you and to the wider community.
Excellent. Dr. Amit, any last words?
I would just say, please communicate if you're in distress, if you're thinking of not wanting to be here. Communicate to your loved ones, communicate to your GP, and talk about it.
Dr. Amita, any last words?
I'd just like to say that a message that self-care is not selfish, and emotional self-care will take you a long way.
What beautiful words. And before I conclude, I want to thank the audience first of all. And I really want to thank the people who have been behind the scenes, who are not in front of you in Facebook. And they've been helping out to bring these presentations to all of you. And they consist of Dr. Raj Killan, Dr. Aziz, and Sid, all behind the scenes. And a special thanks to the audience, without which there's no point in having this get together. I also want to conclude that this is the second last session of the Healthcare Awareness Society of Australia. There'll be another session next week. Following that, there'll be a gap, and then we will restart next year, possibly with a reduced frequency. Please keep tuned for the next few announcements that will keep coming up. And once again, a big thank you to all the panel members for having joined us. And a big thank you to the people behind the scenes as well, who have been working through. Now we've got 2 or 3 questions before. Does anyone want to say anything else before I jump to the last 1 or 2 very important questions that have come up last minute? No. So with the frequency of suicide, David, did you mention that there are more than 3,000 suicides in Australia every year?
I didn't mention it as a number because I think we all get blown away by numbers. But as I say, if you think of it, that a bus full of people die every week, that's about 60 people every week. And for every suicide, about 30 people attempt it. So that's about 1,800 people a week attempt suicide, roughly 100,000 a year. And then, as I say, the real target audience is the 2 to 3 times that number who are strongly thinking about suicide. So at any point in time, there's 250,000 people thinking about attempting suicide, and it's telling them the sorts of things that we've been talking about this morning, ranging from resilience to self-care to making sure you confide in someone and talk to someone, and using our text if necessary, because the research shows that connections and self-care prevent suicide attempts.
And I do think this question came up in the question and answer, but it didn't get really addressed to the live audience. It's the leading cause of death of Australians between 15 and 54. Is that right?
Yes, that is correct. It's quite a shock to people. It's about twice the death rate from car accidents, but certainly it is and has been for very many years, unfortunately, in Australia. You look around at the people you know, age 15 to 24, 25 to 34, 35 to 44, and think what are they going, what's the risk of death? And it is for them, unfortunately, suicide. When I lecture to the final year medical students, I ask them, what lives are you going to save if you are as doctors? And they are quite shocked to think about the figures I've just told you.
Excellent. And let's end on that positive note that I hope we have been able to touch some people, help some people who are survivors of relatives who have, or friends who have done something to themselves. And I hope we can prevent some people from harming themselves in the future. Thank you so much, everybody. And thank you for your participation today.
Thank you, Sunil. Thanks for having
Thank
us.
you.